Bismillahirrahmanirrahim. My dear friends, fellows, and students. Now, this is the topic of the pleural effusion and empyema. Because it's a big topic, if you include the pneumothorax, so I will separate it. And I am Professor C. Ali Haider, representing Jinasin Medical University, where I am working as visiting professor of medicine. It's a big topic, it's a very common topic, although according to my friends and colleagues it is a short topic, but I say it is a long topic. How many cases you have seen of pleural effusion? This is my question to many of us. In my 45 years of clinical experience, I have seen 2,500 to 3,000 cases of pleural effusion and about 10 to 15 cases of empyema and about 50 or more than that pneumothorax. Now, this is the subject of the internal medicine pulmonology, division of pulmonology, but the surgical intervention is much in this. So it is a part of the surgery also. You will cover it, we will cover it on both aspects. The definition of this is a collection, actually, of the fluid in between the parietal pleura and the visceral pleura. That is called pleural space. And this is the potential space as the space created by many parts of the body, like, for example, the peritoneal cavity, peritoneal space, like meninges, subarachnoid space, subdural space, and the same fashion in the synovial spaces, interarticular spaces, and so on. Now, the parietal layer of the pleura is innervated by the somatic nerves. The visceral pleura is innervated by the visceral nerves. So, visceral pleura, if it is involved only, not the parietal, there will be no pain. You will not experience pain. If you analyze this fluid, the fluid is lubricant actually, because the lung will expand and definitely it is collapse afterwards. It is inspiration and expiration. It needs space, it needs forces, it needs the lubrication. The normal pleural fluid analysis says is about 0.3 milliliter per kilogram body weight. The patient of the 70 kilogram. The patient on the side of 70 kilogram is 0.3 milliliter per kilogram. So, how much fluid is there you can see. That is, if you will deal with the normal fluid of 70 kilogram person, it is about hardly it comes a very, very less amount, less than an ml, spreading all over the pleura, the space. Where the protein is 1.5 gram, pH is alkaline, 7.60, cells are 1700, there the 75% are macrophages, because the macrophages are the defense mechanisms. Lymphocytes is part of it, 23% and 2% mesothelial cells, which are always regeneration in process, shut off and regenerate. And this is the fluid produced by the parietal pleura and absorbed by the visceral pleura in a continuous process. So mesothelial cells will secrete it and it is collected in the pleural space. pleural space should be virtually fluid-free. It is hardly 1 ml which is spread all over it. A very, very small amount is there. Only part as lubricant. The fluid accumulates in the pleural space by 3 mechanisms. Increased drainage of the fluid into the space. If there is increased drainage of the fluid into the space by the outside, or increased production of the fluid by the cells in the space, and or the decreased drainage of the fluid from the space. It's possible like this. Whether fluid is secreted by the mesothelial cells in a large amount, or it is filtered by the mechanisms and elsewhere in the body, or it is a blockage of the other side, the visceral pleura where lymphatics are draining the fluid from the space. So it means that the development of pleural effusion means that if there is increased pulmonary capillary pressure, for example in congestive cardiac failure, the pressure is increased, which will secrete more and more. Not formed, it is secrete. Capillary permeability is reduced with pneumonia. If it is removed, then the accumulation occurs. Interpleural pressure, it will act as again because of the collapse of the two sides. Again there will be a reduced interpleural pressure, and reduced interpleural pressure will accumulate the fluid. Or increased plasma oncotic pressure, for example hyperbilirubinemia or others. The oncotic pressure will be increased, or pleural membrane permeability, malignancy, or in cases of lymphatic obstruction like malignancy, like diaphragmatic defect, hepatic hydrothorax. It is defect or holes or foramen formed in the diaphragm, and it will form this thing, and the thing is that is it is the thoracic duct rupture which will cause the chylothorax. So thoracic duct rupture will cause the chylothorax. So it may be chylous in nature, the lymphatic in nature, and it mixed with the other fluids. It may be the rupture of the esophagus which accumulates the fluid in the space. The causes are transudative or exudative or chylous or hemothorax. Now transudative, usually bilateral it is seen in the congestive cardiac failure, in the cases of cirrhosis, in the nephrotic syndrome, constrictive pericarditis, peritoneal dialysis. Exudative, usually unilateral, it is parapneumonic pleural effusion. You see in most cases, it is the tuberculosis, it is the fungal involvement, or connected to disorders, or malignancy, or pancreatitis, or subphrenic abscess, or severe dengue fever. It is seen today. Nowadays, dengue fever is often on. I have seen 2 cases of pleural effusion. Radiation pleuritis, chylous, like congenital chylothorax, or post-traumatic. It may be chylous. And then hemothorax is blunt trauma or malignancy penetrating into the pleura. Now, how do you say that it is transudative or exudative? You will see later on. The patient usually in a small pleural effusion is asymptomatic. Pleuritis will cause the pain, for example in pneumonia. When there is a small pleural effusion, the pain will go. Large pleural effusion, pleuritic chest pain, no, is a pressure pain actually. It may be abdominal pain during inspiration or coughing. It is possible in this fashion because only the parietal pleura is sensitive, not the visceral pleura. The patient may refer to lie down on the affected side to decrease the respiratory excursions. There may be cough, there may be fever. The primary process or cause of this pleural effusion. In cases of the respiratory distress, It will cause the respiratory distress. If there is a large amount, it will cause dyspnea or orthopnea or cyanosis. Examination, now this is very important. You have to remember the clinical examination of the chest in cases of acute inflammation, that is in pneumonia, in chronic inflammation, that is tuberculosis, or the result of these two is the pleural effusion, or you have to also know what are the clinical features in the bronchopneumonia or the multiple opacities, what are the findings, and you have to do also in cases of the malignancy, what you find. In cases of atelectasis, you have to remember the clinical findings, and in cases of the pleural effusion, and in the cases of the pneumothorax. So examination of the tracheal deviation, if it is large pleural effusion, to the opposite side, this is the pushing effect, or bulging chest wall on the affected side with a reduced movement if it is a large pleural effusion. Because the fluid is not a good conductor, it will decrease vocal phlegmatis, TVF. And dullness to percussion, of course, it will be dull, it should be stony dull. Decrease or absent breath sound, because breath sound will not transmit into the fluid. Diminished whispering pectoral leaky. Pectoral leaky is only finding when you whisper and you listen with the help of the stethoscope. That is called whispering pectoral leaky, seen in cases of the consolidation. Here it is just opposite, it is diminished, and the decreased vocal resonance, VR. Or there will be agophony. Agophony means just like the goats, which is humming, sound of the goats, numbing sound of the goats. They call agophony. Agophony audible at the upper level of the pleural effusion because of the partially collapsed underlying lung, which is connected with the bronchus. Immediately there is a diminished vocal resonance, and you go just up, it will become increased, and just like a agophony type of a thing. Now, another finding in cases of the acute pleuritis, you find the pleural frictional rub, and inflamed parietal and pleural rub each against, and it is continuous, and it is lathery, and it is superficial, and it is rough in character. Hard both in the inspiration and expiration. It's a to and fro type of a sound. Disappears rapidly as the size of the effusion increases. If the patient remains paraxial or unwell after 48 hours after admission of pneumonia or parapneumonia pleural effusion, empyema must be excluded. So the thing is that if you have given the antibiotic parenterally an admitted patient and there is no clinical improvement, consider the parapneumonia pleural effusion or consider the empyema thoracis. Diagnosis is chest radiography. Be able to diagnose between 200 to 250 ml of the fluid will block at the costophrenic angle. At least 150 ml is needed for the blunting of the costophrenic angle. Chest radiograph required in the lateral decomposition also, more sensitive index, and can pick up as little as 50 ml of the fluid, where the fluid accumulates in the costo. It is a costophrenic angle is the costovertebral angle. If you lateral view, it is known as costovertebral angle. Where a small amount of the fluid must be there. If it is less than that, ultrasound can pick. If it is more than this, ultrasound is not able to pick. The only thing for the evidence is just go for the needle aspiration and see whether the fluid is present or not. These are the stages to diagnose of the pleural effusion. Collect the pleural fluid and go and send to the analysis. Ultrasonography already said that it can locate also less amount of the fluid, 30 ml or 35 ml. You can pick up, and loculation can be picked up, the consistency can be picked up, and easy to go for the diagnosis and empyema thoraces without needle aspiration. Best thing is the HRCT, differentiate between the fluid collection between the lung abscess or tumor, which has got the same type of the cavitation, has of the collection of fluid. The same clinical features are the same. So this HRCT will be the gold standard for this to diagnose. So this is how the anatomy is described in case of the pleural effusion. As C in this cases of the HRCT, that small pleural effusion, this is the mediastinal window, and this is the collection, the costovertebral angle. This is costovertebral angle. The vertebrae is there, and this is diaphragm, where you find this fluid like this. And then pleural fluid analysis, routine tests will be done, cross-examination, pleural fluid serum protein ratio, or it may be possible when you do the pleural fluid albumin, the ratio of the serum albumin, pleural fluid to the serum LDH ratio, and cytology and culture will be sent for the DR and the AFP, and for the culture and sensitivity, for the gene expert you can do, and you can do the microscopy for the malignant cells. Pleural fluid analysis is that test in the selected cases only. You suspect, you are not suspecting the transudate, or you are not able to classify as transudate or exudate. You go for the pleural fluid cholesterol levels, pleural fluid serum cholesterol ratio, lactate in the fluid, enzymes in the fluid, interferon gamma, CRP in the fluid, and the tumor markers in the fluid, or rheumatoid factor in the fluid. Transudate typically clear, pale yellow, stalk odorless, and do not clot. Exudate show variable degrees of cloudiness or turbidity, and they often clot if not heparinized. This is the difference between the transudate morphologically and exudate. A feculent odor may be detected in anaerobic infections, that is empyema. Gross examination also revealing the bloody pleural effusion. Hematocrit of 1% suggests trauma. If it is, you calculate the hematocrit, trauma or malignancy of pulmonary infarction. A pleural fluid hematocrit greater than 50% of the blood. If it is more than 50%, of the blood hematocrit, this is a good evidence for the hemothorax. So, bloody pleural effusion is another terminology, and another terminology where we are using here, hemothorax. The hemothorax, turbid milk, in another case, the turbid, milky or bloody specimen should be centrifuged, and supernatant fluid will be examined. If the supernatant fluid is clear, the turbidity is more likely due to the cellular elements, the debris. If the turbidity persists on the upper layer after centrifugation, a chylous effusion is likely where the more of the fats are accumulating on the supernatant fluid. The Wright's criteria is describing and asking in the examination. Sensitivity 99% and specificity is 98%. The criteria is that the pleural, the principle is that in the exudate there is more proteins, and the transudate is less proteins. LDH is more in the exudate than in transudate. Now this is the how, and the specific purity is more of the exudate than the transudate. On the basis of this principle, they found that the pleural fluid protein ratio with the serum protein. If it is less than or equivalent to 0.5, it is transudate is more than 0.5 exudate. Pleural fluid LDH to serum LDH, if it is less than 0.6 or equivalent, it is transudate is more than 0.6, it is exudate. Remember by heart, because they are asking in the examination. Now, pleural fluid LDH levels, it is 2/3 upper limit normal, it is exudate, it is lower than 2/3 of the upper limit normal, it is exudate. More than that is exudate, less than 2/3 is transudate, means that it is less than 200 and it is more than 200 in the exudate. This is light criteria. At least two findings should be there to classify the transudate and exudate. Either one, two, three. There are three parameters. Two should be positive for the transudate or exudate. Microbiological examination is gram staining, and you go for the AFB staining. That is, you have to do the specific test for it. And for the AFB, and we are doing today the gene expert also. But remember that in pleural effusion, the sensitivity is only the positive culture found in about 50 to 70% of cases, not in 100% of cases. So again, there is suspension whether it is tuberculosis or not. The chemical analysis in certain cases, the glucose level of the normal pleura, fluid, transudate and most exudate is similar to the serum levels, whether transudate or exudate, very similar. For example, 130 milligram was the random blood sugar. Again, the pleural fluid has got about 125, 126 is the glucose level. So there is no difference between the transudate and the exudate as far as glucose is concerned. But the decreased pleural fluid glucose accepted as a level below 60 milligram or a pleural fluid or serum glucose ratio less than 0.5 is more consistent with the dramatic in the rheumatoid arthritis, number one. Number two, in the pyothorax. There are two important conditions in which glucose is lower down. Otherwise, it is similar in the transudate and exudate. Lactate levels are also useful. Infectious patients, they have got higher bacterial and the tuberculosis infection than in other pleural effusions. So in the exudate, more lactate are found in exudate. Values greater than 90 milligram per deciliter have a most predictive value for the infectious pleuritis of 94% and negative predictive value of 100%. You can exclude it 100%, sure about it. Serum amylase, here is pleural amylase. Elevation above the serum level, usually 1.5 to 2 or more greater times, indicate the presence of pancreatitis, which is oozing out. What is called, we call the sympathetic pleural effusion, esophageal rupture, bone have syndromes, or Morrison syndrome, or malignant pleural effusion. Elevated amylase derived from the esophageal rupture of pregnancy is the salivary isoform, actually, which differentiates it from the pancreatic amylase. So isoenzymes can be calculated in certain labs only, not in our country. LDH, pleural fluid LDH level are raised in proportion to the degree of inflammation. More is the inflammation, more is the LDL. So it is higher in the exudate than in the transudate. It is much higher in the pyothorax. Now, and if you cannot decide the exudate that it is tuberculosis or not tuberculosis, adenosine deaminase level, if it is more than 40 units per liter, it is definitely tuberculosis. If it is 39, for example, or it is 41, it may be possible, may not be possible, maybe error is there. Go for another test, that is interferon gamma. Now, interferon gamma levels are significantly increased in the pleural fluid with the tuberculosis pleuritis. So it's got a sensitivity of about 99% and the specificity is about 98%. First of all, you do the adenosine deaminase level. If it is not conclusive, then go for the pleural fluid interferon levels. They can ask in the postgraduate examinations, how will you determine that it is tuberculosis or not? More macrophages are there, more lymphocytes are there in this condition, no doubt. But it is not conclusive. You have to do 100% sure. If the culture is positive, that is all right. That is the direct evidence. But if it is not conclusive, you cannot do the culture, then adenosine deaminase level followed by the interferon gamma level if it is not conclusive. pH is actually alkaline in nature. It is good. If it is decreasing, it means acidic type, it is the cause of the paranemonic type of the exudate, less than 7.30. So acidic pH will be seen in the infected process. If it is lesser than that, complicated paranemonic effusion like empyremathoraces will be there. And below 6 is the characteristic of the esophageal rupture, where acids are accumulating because of the hydrochloric acid. pH will become more reduced. So pH can be determined. It should be, if it is possible. Lipids in the pleural fluid identifying the chylous effusions and pleural fluid triglyceride levels are more than 110 indicate a chylous effusion. Triglyceride levels are more are seen in the chylus, means the thoracic duct is blocked and is ruptured, where it is loaded with the triglycerides. So it is seen in the cases of the thoracic duct obstruction. Values from 60 to 110 require lipoprotein electrophoresis to confirm a chylothorax. If you do the electrophoresis, lipoprotein electrophoresis, what type of lipid content is there? Non-chylous effusions, triglyceride level is less than 50, and no chylomicrons on the electrophoresis was seen. You will see only LDL or other parameters of the lipid profile in the pleural fluid. Immunological studies can be done. Approximately 5% of the patients with the rheumatoid arthritis and 50% patients with the SLE develop the pleural effusions. Immunological study, because the rheumatoid arthritis are a factor. It's positive in rheumatoid arthritis is more seen in the SLE. Rheumatoid factor is commonly present in the pleural effusion associated with the seropositive type of rheumatoid arthritis, not seronegative type of the rheumatoid arthritis. ANA teachers may be useful in the diagnosis of effusion due to the SLE. Now, treatment should be aimed at the underlying disease, of course. With the transudative overload, fluid overload, cardiac or the renal failure, diuretics, preload, decrease the preload, and the fluid management is the answer. Or in cases of, for example, it is caused by the hypothyroidism, then manage hypothyroidism. Nephrotic syndrome and the cirrhosis of the liver will cause albumin effusion. Salt-free albumin will definitely decrease the level of the pleural effusion. Tubercular pleural effusion, you have to use the anti-tubercular drugs 2 months plus 4 months. Chylous thoracosynthesis is a placement of the tube followed by the feeding with the MCT, that is, you have to pass the gastric, actually direct gastric, feeding is possible because of the rupture or because of the collection of the fluid which is also encasing the esophagus. Continuous development, discontinuation of the oral feeds and start the total parental nutrition. Somatostatin and octreotide has a role in cases of traumatic hemothorax. It will cause the speedy drainage of the blood with the proper replacement. Recurrent pleural effusion due to the pregnancies. If it is a recurrent type of the pleural effusion, you go for the catheter replacement unless the fluid is clear, or you go for the blockage of pleurodesis, this is called. You induce the inflammation at the spot where the fluid is oozing and block it by some substance. There are many substances that are available for it nowadays. At our time we used talc induction pleurodesis. Parapneumonic effusion, analgesia, supplemental oxygen, I have already described when I have talked about the pneumonia. So basically we give the analgesia, supplemental oxygen and broad spectrum antibiotics in the commonly required pneumonia, for example. We use the beta-lactams. If it is a very large pleural effusion, or you are not able to differentiate between the pleural effusion is transudate and exudate by the history taking and by your examination, there are two types of the pleural fluid analysis. Pleural fluid analysis may be therapeutic, it may be diagnostic. If it is diagnostic pleural tap, then it should be collected and in the syringe, and then you do the examination as a whole, that is the protein levels and the LDH levels, in specific cases the other things, the specific gravity and so on. Complication in inserting, maximum insertion will be given here at the posterior axillary line, or the what we call as the more lateral interscapular line, where the maximal percussion node was present. This is the side where you put the needle inside. But if it is sufficient fluid to accumulate to cause the respiratory embarrassment, it means that the fluid is much, you have to place the underwater seal. So our bottle should be available and the catheter is passed rather than needle. And you should maintain the catheter there, so much of the fluid should be drained in the bottle. This is chest tube drainage. Because if it is exudative or it is bloody type or hemothorax, possibility that it is clot will occur, and you have to remove that clot because it is blocked. You have to give the thrombolytic therapy. Inside the tube, you give the streptokinase with 0.9% saline, wash it, urokinase, wash it. Because the streptokinase, they are fibrinolytic agent, they may be associated with the hemorrhage for a few days. So, but you have to remove the clot or the obstruction in any case. Nowadays they are doing the video-assisted thoracoscopic surgery, that is called VATS, or open decortication, where they localize it and they perform the surgery there. Just like the laparoscopic cholecystectomy, same. The decortication can easily be found and it will be recorded also. So VATS, that is the video-assisted thoracoscopic surgery, is available in certain centers only. Empyema thoracis is the collection of the pus as exudative in the pleural cavity. And it is the empyema of the purulent pleurisy, pyothorax. Etiology is mostly the streptococcal aureus or streptococcus pneumoniae. But tuberculosis can also cause. Hemophilia influenza will cause. It may be rupture of lung abscess. It will be contamination of the trauma or thoracic surgery or by mediastinitis or the extension of the intra-abdominal abscesses inside. If a liver abscess is ruptured into the costophrenic angle on the right side, and it will cause the empyema thoracis. In this fashion, the empyema occurs. The empyema history is that the preceding history of pustules or blunt trauma to the chest wall, viral infection, severe malnutrition, contagious extension of the infection tube, from tube or from this. You have, that is called the iatrogenic type of pyothorax. The exudate should be now is a pyothorax. It means the glucose levels are very reduced. A lot of neutrophils are there now, because the normal the neutrophils are not there. You see the neutrophils in the pleural fluid. Empyema has three stages: exudative, febrile, purulent, and orgasmization. Empyema. First is the exudative stage for 1 to 3 days, then it's followed by the febrile, purulent stage for 4 to 14 days. In these two stages, you can manage it. Otherwise, organizational stage will cause and fibrosis occurs. That will lead a problem because the inspiration will be definitely reduced after resolution. So these are the pathology which describe how it occurs, the exudative stage, how fibrillatory stage, and how organization occurs. It is the pathophysiology which is described. Clinical manifestation are in this case, again the fever with the rigorous pain, and you will find the movement which is less, and the stony dull notes, percussion notes, and you will also find the breath sound will be absent at that time, at that site. Diagnosis is done by the pleural tap or by the ultrasonographic indirectly. If there is septation or seen in the pleural space, it means that it is empyema in the ultrasonography. Bacteria are present in the gram staining, and the pH is less than 7.20. It is acidic. Glucose is less than 40 milligram. LDH is more than 1,000. And there are more than 100,000 neutrophils. Neutrophils are not present usually. This is the diagnostic criteria. Culture must be performed, definitely with the organism there, and sensitivity index should also be calculated. And comparatively, also the blood cultures also have a high yield at that time because of the septicemia and pyemia associated with this condition. Complications are, it will form bronchopleural fistula, which needs the adequate drainage and nutritional support, etc. And if it is a bronchopleural fistula of more than 2 to 3 weeks, requires decorticational surgery or lobectomy or thoracoplasty. So there are a lot of complications associated with this condition, that is pneumothorax. Pneumothorax also occurs because of the entry of the air. Purulent pericarditis can occur because of the extension and abscesses, peritonitis, septic complications because of the septicemia. Septicemia means that all two or three systems of the body is involved. Peel may restrict lung expansion because of the peeling. May be associated with the persistent fever and temporary scoliosis, pain there, and there will be a spasm of the muscles at that site. And patient, if you take the X-ray, there is a reactive type of scoliosis is found. There is empyema necessitans, which is outside. There is empyema, and there is ulcerative lesions on the site where the tuberculosis was there. This is the called empyema necessitans, mostly seen in the tuberculosis. Or it may cause the gastropleural fistula also in very rare cases. Antibiotics are the answer, and the thoracosynthesis. That really you have to go for the placement of the catheter and underwater seal. That should be done. Where you find that the other agents are not useful, you have to do this bottle underwater seal, which is not possible and is a large one, and the spaces are much involved. You do the video-assisted thoracostomy surgery, the decortication, and you will also inject the streptokinase to cut the septations, and then you can do the open decortication, open surgery. If there is significant pleural thickening, you have to peel it off, the pleura, in the open chest surgery. The long treatment is there. You have to treat it, and PAMA is excellent prognosis. Otherwise, if it is a recurrent one, you go for the broad spectrum antibiotics for the prolonged period of time and call the surgeons for the intervention. So this is the discussion about the pleural effusion is concerned. You know that what are the causes of the transudative pleural effusion and the exudative pleural effusion. You have to know what is the diagnostic criteria, specifically speaking for the final year, the large criteria they should know. How will you manage this case? Definitely depending upon the type of the pleural effusion, we will manage it. These are simple answers. Because of the short of time, I already taken 41 minutes. Inshallah, we will meet it again for the other related subject of the pneumothorax or hydropneumothorax to end the pulmonology. وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.